A common question I get is, how do you tell the difference between pneumonia and CHF? They both cause shortness of breath, they both can give you rales in the lungs. So how do you tell the difference in the field? Some agencies still carry Lasix, and giving Lasix to a patient with pneumonia can actually be deadly. So it's important for our paramedics to know the difference, to be able to tell clinically the difference between these two things. And it actually can be fairly simple. We just really need to look at the pattern, something I call pattern recognition in medicine. So what I want to do in this brief lecture here is go over the patterns that tell us when we've got pneumonia and when we've got CHF. So let's start off with a sort of a case here. So EMS is called by a local nursing home for a patient complaining of shortness of breath. They find an elderly man lying in bed with an O2 sat of 80% with labored breathing. Sample reveals the man was found by the staff with shortness of breath and decreased level of consciousness this morning. The man normally is confused but talkative. There are no allergies. The medications are Aricept, albuterol, and Risperdal. Past medical history is positive for a stroke, and the man is fed continuously via a G-tube. So the patient is treated with oxygen, and the O2 sat rises from 80 to 95%. The vitals reveal a pulse of 110, a respiratory rate of 26, blood pressure of 110 over 50, and the skin is dry. Rales are heard in all lung fields. So we hear rales, the patient's short of breath, he's breathing fast, he's hypoxic. Should the medics administer Lasix? Okay, so what we want to do is actually look at pattern recognition and to try to tell the difference between these two things. Diseases have common themes and common clues that we look for. We need to learn the patterns to decipher the diagnosis. And one key thing that paramedics should learn is the most common 100 or so medications, because if you know the medications, then you'll know the patient's past history, whether or not they can speak to you or not. So here's some common patterns between pneumonia and CHF. On the pneumonia side, you generally have a history of lung disease and lung medications. It's important to realize that pneumonia is a lung disease. People with lung disease tend to get more lung disease. So if you've got a COPD patient, it's far more likely they're short of breath because of either COPD exacerbation or because of pneumonia. In pneumonia, you get a fever. However, you have to be cautious because lack of a fever doesn't mean it is not pneumonia. Just think about the last time you had the flu. You didn't have fever 24/7. Fever comes and goes. But if you have a fever, that pretty much clinches the diagnosis. Lack of a fever, that doesn't tell you either. Low blood pressure, wide pulse pressure are common in pneumonia. These patients tend to be chronically run down and ill, so they tend to live at a nursing home. Aspiration risk is a common theme in pneumonia. These folks don't swallow normally and they can get aspiration pneumonia. They tend to be bedridden or immobilized. Folks that don't move around a lot are higher risk for infections. Folks with dementia are also at higher risk for infections. Their skin tends to be dry and hot as opposed to diaphoretic. The sepsis that you get from pneumonia and other infections typically gives you altered level of consciousness. And pneumonia, if you can get a really good history, you'll see that pneumonia symptoms are pretty gradual onset. On the flip side, congestive heart failure it's a form of heart disease. So patients with heart disease get more heart disease. So if you've got a patient who's got a history of bypass surgery or valve surgery, or they've had an MI before, they're far more likely to get congestive heart failure. They will always have a normal temperature. They're not going to have a fever with congestive heart failure. They tend to have high blood pressure, and not actually high, but super high blood pressures, like systolics in the 200s or higher. These folks tend to go into congestive heart failure. They get bad, they go to the hospital, they get fixed up, and they end up going back home because at their baseline, they're relatively healthy as opposed to the pneumonia folks who are relatively run down. They get orthopnea, which is shortness of breath while they're lying flat. They have edema, jugular venous distension. Their skin tends to be clammy, cold. They can have hepatojugular reflux, and the onset is often in congestive heart failure pretty rapid. So I want to go over some pictures here because a lot of times you don't even need history or the background. You can just look at your patient, you can see what's going on. So right here, if I told you that this patient was short of breath, what would you think? Well, this clearly is a patient with jugular venous distension. Jugular venous distension is a sign of fluid overload. So this is a patient with congestive heart failure. On this slide, we actually have a couple of clues. So on the first one, you'll see that, once again, we've got this distended vein. This is actually an example of hepatojugular reflux, which I'm going to show you how to do in a moment here. But we also see this patient has a zipper scar. So this is a patient who has had surgery. So if you come across a patient complaining of shortness of breath who has these signs, you've got to think about congestive heart failure. So we're going to go over the technique to determine hepatojugular reflux. JVD is jugular venous distension, which is when the body's engorged with blood, you'll see the veins in the neck pop up. When it's more subtle, though, you have to actually do this maneuver called hepatojugular reflux. So what you do is put your patient in the typical position. You're looking for JVD, have them turn their head off to the left, and you're looking right over the neck here, looking for jugular venous distension. If you don't see it, you can push over the liver in the right upper quadrant. When the body becomes engorged with blood, what happens, and fluid overloaded, the liver will become engorged, and you can squeeze on the liver sort of like a sponge. It'll squirt out the blood into the venous system, and that'll make the jugular vein pop back up. So what you do is just take your hand, put it over the right upper quadrant, and push down and in for several seconds constantly, and while you're observing over the jugular vein. And what you'll see is, in the folks with mild CHF, the jugular vein will pop up, and that is hepatojugular reflux. A simple exam looking for subtle CHF. So here we've got a patient, and I'm not giving you any history. All I'm showing you is a foot. And when you look at the foot, you see there's pitting edema. And this is what pitting edema means, that you push your finger in it, and it creates a pit, and the pit stays there. And if you look, you can see the other foot in the distance there in the background of the picture, and both feet have this pitting edema. Again, another example of pitting edema. So this is another patient with fluid overload, so this is going to be congestive heart failure. So it's important that when you do your physical exam, you do a head-to-toe physical exam on everybody, kind of like a primary trauma survey that we're pretty good at in trauma. You do a head-to-toe exam. Well, medical patients should get the same head-to-toe physical exam looking for clues like these. Now, this is a variant of congestive heart failure. Remember, I said that typically in CHF, you'll have really, really high blood pressures. And that's true for most forms of CHF, but there are some people that have chronic severe congestive heart failure due to really weak hearts. They really have pump failure, and they have chronically low blood pressure, and they are always in congestive heart failure. So their blood pressure tends to be really low simply because their heart's not strong enough to actually give them a high blood pressure. And when you look at their legs, they've got so much edema all the time that the iron in the hemoglobin leaches out and stains the skin and gives you this appearance with what we call hemosiderin pigment. And in the top of the picture, you can see the other leg looks the same. If this were just on one leg, you might think that this is from chronic blood clots in the leg. But when it's both legs like that, that's really a poor chronic circulation issue, and it's this chronic severe congestive heart failure. These folks are always in CHF. It's just really a matter of degrees of CHF that they get into. And that's the exception to the high blood pressure that you'll see with congestive heart failure. So here again, I'm just giving you a foot. And if you look at that and I tell you this patient's short of breath, what would you think? Well, first, what is that thing that they're wearing on their foot? This is a boot that we put on patients that are relatively immobilized to prevent pressure sores. So this tells you this is a patient that doesn't walk around a lot, they're pretty well immobilized, and we know that people that don't have good mobility are at high risk for pneumonia. This tends to be a chronically disabled or a chronically debilitated patient. So this would be a pneumonia patient. Now you look at this case, and we've got multiple clues on here to suggest that this is pneumonia. First, you see that we've got some pursed lip breathing. Then we've got some barrel chest looking thing going on over here. And then we've got our typical tripod position. So this is clearly a patient who's got some lung disease. And remember, pneumonia is lung disease. So this is the patient with COPD, and if they get short of breath, you've really got to suspect pneumonia. Even if you hear rales in the lungs, the rales is probably pus, not fluid. And those are the two things that really give you rales in the lungs. You could have fluid from congestive heart failure, or you could basically have pus, which is pneumonia, and they sound very similar. So you really have to look at the pattern to figure out the difference between the two. Now here's another one. This here is a PEG tube, and it's used for folks that can't swallow normally. So these people, either they've had a stroke or some other swallowing disorder, they can no longer eat through their mouth. So we'll feed them directly into the stomach through this tube. But that doesn't make the saliva go away. These people still produce saliva, and there's bacteria in the saliva. So basically, they'll be swallowing the saliva down the wrong pipe, and all that bacteria will get right into the lungs. So if you see a patient with shortness of breath and they've got one of these things in, almost always it's going to turn out to be aspiration pneumonia. So if you roll up on scene and you see one of these devices in there, this tells you that this is a patient that has poor mobility, chronically ill, and if they're short of breath, the odds are you're dealing with pneumonia. So now I'm not even giving you a patient, no history, I'm just giving you scenes in the environment. Again, this is part of the pattern recognition of pneumonia. If you roll up on scene and you've got a building that says rehab or nursing home like this one does, and you've got a patient complaining of shortness of breath, you can bet that you're probably dealing with pneumonia. So now, I'm not giving you a patient, I'm not giving you any history, I'm just giving you an address. So again, this is pattern recognition. You go to a patient in the nursing home, that tells you it's a chronically debilitated patient. They're chronically run down, poor immune system. If they're short of breath, they're at high risk for infection. Plus, when you've got quarters where folks are living with lots of other people, high density environments, well, that's where you get infections from. It's from other people. So when you've got a scenario like this is a real setup for infectious diseases, including pneumonia. So now that we've gone over the pattern, let's go back to our case. And I've highlighted some of the key clues in this. So EMS called by a local nursing home. So there you go. Nursing home is a key risk for pneumonia. Elderly folks are a key risk for pneumonia. Decreased level of consciousness is a symptom of pneumonia. The patient's normally confused. Dementia is a common pattern in pneumonia. The patient's taking Aricept, albuterol, and risperidone. Well, what are these medicines for? Aricept is for dementia. Albuterol is obviously for folks with lung disease. And risperidol is also used in patients who are having psychotic problems, which is common with dementia. So the past medical history tells us this patient is a setup for pneumonia. Patient has had a stroke. Again, folks who are chronically run down or poor mobility, they're at risk for infection. He's fed with a G-tube. That tells us he can't swallow, so he's going to be aspirating bacteria. And here are the vital signs. Pulse of 110, respiration is 25, and blood pressure 110/50. Well, I can tell you, and we'll do another lecture on this, these vital signs are screaming septic shock. So we'll do another episode on how you dissect the vital signs to see that, so you'll understand the background behind that. But this is classic septic shock vital signs. So you hear rails in all lung fields, and should the medics administer Lasix? The answer is no. You're clearly dealing with a patient with pneumonia, septic shock, and rather than give Lasix, you actually need to give this patient 1 or 2 liters worth of fluid, just the opposite of what you'd be doing with Lasix. So I encourage you to find out what your patient's diagnosis turns out to be when you drop them off in the emergency department so that you can learn the last page of the book, or basically the final end of the story, so you can find out if your initial field impression was correct, and then if not correct, you can adjust your pattern recognition for the next case. Thanks for watching. I appreciate it.